Assalamu alaikum wa rahmatullah. This is the last lecture in the course Dent 352 Oral Diagnosis, and it is treatment planning process. For this lecture, the references are two articles and a textbook. The lecture learning outcomes will include the following list. Reasons for formulating a treatment plan, factors affecting treatment plan, problem listing, guidelines, treatment plan phases, treatment plan documentation, and consent. Now, we have to know why we are going to formulate a treatment plan. Why not leaving the patient with tooth by tooth treatment plan or appointment prepared treatment plan? If you formulate a comprehensive treatment plan for the patient, you can identify problems of varying importance and urgency, so you can list them accordingly. You can start with the most important or most urgent dental issue and then move on to the less significant one. You need to provide appropriate solutions for the dental findings of the patient, so you need to arrange them and list them in sequences or phases. And our ultimate goal is to provide the patient with a masticatory system which is well functioning, okay, and is free from the active disease and is aesthetically pleasing to the patient at the same time. So all of these 3 points will allow us to formulate a sequential treatment plan with a prioritization of the treatments. The treatment plan will provide us with less stress to the patient, less stress to the dentist, because both will know what is coming next. So there will be effective use of the clinic time. The dental assistant will prepare the clinic according to the scheduled point or a phase of the treatment plan. So overall, the treatment plan will give us logical progression through various phases and will achieve the patient expectations. Okay, now we have certain circumstances that we can accept. We have exemption from having a sequential treatment plan and phases of treatment plan. This exemption will come if the patient is coming to your clinic seeking for an urgent treatment only, and he will not come back to your clinic. So in this case, you cannot even have the time to prepare this sequential treatment plan. You can obtain the history, you can collect the data, especially the medical history. Please don't forget the medical history, even if the patient is having only one single urgent chief complaint. So the medical history must be obtained. Why? Because we want to make sure that we don't have systemic conditions that will have side effects on our dental treatment. Or maybe the patient will have complications on the dental chair, like a patient who is on anticoagulant, like warfarin, his INR supposedly is 3 or 3.5. You don't want to have extraction on that patient with an INR which is that high. So we must document the medical history of the patient. Okay, now after we appreciated the importance of writing down a treatment plan, we need to start talking about how to arrive at a manageable treatment plan. Sometimes you don't want an ideal or a treatment plan that cannot be managed. Okay, now we need to arrive at a good treatment plan, a good manageable treatment plan. We will start with collecting the data. Do you remember the lectures of data collection, number 1 and 2, and then correlate these information together to arrive at a diagnosis. So data collection comes first, and then a diagnosis after relevant investigations and special tests that we learned in the previous lectures. Then we will arrive at the appropriate dental diagnosis. Okay, today in this lecture, we will talk about the last 2 points. Okay, considering different treatment options for the diagnoses and to formulate the treatment plan. But this treatment plan is not our own call. It should be done or prepared with consultation with the patient. And we will talk about the treatment options and alternatives later on. Okay. Now, the dentist need to consider for having or to be able to prepare a treatment plan, we need to consider the diagnostic findings. It is very important to identify the diagnostic findings. What are the diagnostic findings? These are the diagnoses that we will arrive at after comprehensively examining the patient, starting from the chief complaint, medical history details, social history, previous dental history, extraoral examination, intraoral examination, dental charting, investigations, and arriving at the diagnosis. All of these diagnostic findings we need to keep in mind in preparing our treatment plan. And we will specify in a few slides which diagnoses to consider in our problem list. Now, we list the diagnoses, then we need to find some solutions for these diagnoses. And then we need to consider and to keep in our mind the patient. In the previous slide, we mentioned that the treatment plan should be formulated in consultation with the patient. And here we again say that the treatment plan should be discussed with the patient and it should be the patient preference. So we cannot design a treatment plan as we like. We have an ideal treatment plan, but it might not be manageable. It might not be executed. So we need to always refer back to the patient and discuss everything with him. Now, after we finished the data collection, we should arrive at the diagnostic findings. Okay, the diagnostic findings, it can be referred to as problem list. List of the problems, and we can put them in order or in certain sequence. After writing this list of problems, then we can go ahead and start our treatment plan. Before even sequencing or writing phases for treatment plan, we have to discuss the solutions of each problem listed in this in the patient record. Okay, what are the problems to be listed in the diagnostic list? Now, these conditions to be listed, they should be those warranting additional diagnostic evaluation or treatment. Look at the next slide. We have 3 criteria for the diagnostic. For the problem list, we need to list those concerns or conditions that require recognition. I need to recognize, for example, that the patient is having a white lesion of unexplained etiology. Or I need to list that I am recognizing caries. Why? Because either of its significance or because it needs management and treatment. So I will list in my problem list those diseases or conditions that requires recognition, management, or treatment. For example, if you identified a linea alba does not necessitate recognition. Even if you did not recognize linea alba, you will not affect your patient. So it doesn't need management, it doesn't need treatment. So I will not list it in my problem list. Okay, I will not list it there. For example, amalgam tattoo. Even if I identified amalgam tattoo in the patient mouth. Okay, am I going to treat this amalgam tattoo? Does it necessitate recognition or management or treatment? If not, then don't list it in the patient problem list. Why we need to have this list? Because of 3 points. First, This list will provide me with the foundation for the treatment plan, because the lists of diagnoses can justify the treatment I am listing. Without the diagnoses, I don't have justification to treat. Okay, now organization, it is easier to list the diagnoses rather than listing the findings. Okay, you can list a diagnosis like necrotic pulp with periapical pathosis. It is better than listing a large carious lesion exposing the pulp with a periapical radiolucent lesion affecting the this and this and this roots. For example, this is description, while in the problem list you need to list diagnoses only. So diagnoses will make organization better than description. Diagnoses will provide you with professional competence, meaning that I will not provide treatment for the patient that he doesn't need. So if I list problems, I will address them in my treatment plan. It is very important to write and to have this problem list. Okay, let's go back here and talk again about the problem listing. Problem listing, we have to list them by priority, starting with the diagnosis of the chief complaint of dental pain, and then we can list according to priority. We have guidelines for problem listing. We will talk about them here. Now, this guidelines is taken from the textbook reference that I included in the first or second slide of this lecture. Here you have 12 guidelines or sequence or classification of patient diagnoses. You can classify them under these categories. Now, please remember that the patient diagnoses or the problem list are not only dental. You are dealing with a human being. You are dealing with a patient. You have discussed a lot of points with the patient about the dental history, medical history, extraoral examination, intraoral investigations, chief complaint. You wrote down the occupation, the age, gender, everything that was discussed with the patient. It can be listed under the diagnoses or the problem list if it fulfilled any of these criteria. If it really necessitates recognition, if it necessitates management, or if it needs treatment, or if it will affect the treatment of the patient. So here we have the first category will be the chief complaint of the patient. Right here, the diagnosis of the chief complaint. For example, you will say irreversible pulpitis with periapical periodontitis of the upper right 6. This is diagnosis of chief complaint. Then go to the general health issues that impact on dental treatment. So we are following the sequence of the examination sheet. We write the chief complaint diagnosis, and then we go to the medical history if there is something significant that will affect our treatment. For example, I can write down the use of anticoagulant with INR, with unspecified INR. Or I can say type 2 diabetes mellitus uncontrolled. Okay, so right here, any finding that affect your treatment, dental treatment, or might necessitate intervention or will affect the management. After the medical history, we go to the social or the personal history of the patient. If you have diagnosis, if you have certain findings in the personal history, write it down here. In the next slide, we will discuss an example. Other findings from the intraoral or extraoral examination, you can write, for example, solar keratosis of the lower lip. You can write down angular cheilitis. You can write median rhomboid glossitis, any finding extraorally, orally, or intraorally that warrant recognition and management. Then you go to the investigations results and you write down radiographic findings, like, for example, a cystic lesion at the angle of the mandible, multilocular cystic lesion at the angle of the mandible. You write down the disorders of the TMJ if they are there, occlusal abnormalities, limited mouth opening, deviation of the man, anything that necessitates treatment. And now go to the dental findings. In the dental findings, we usually start with the periodontal pathology. In the oral diagnosis clinic, we don't want to be that specific in our periodontal diagnoses. In the perio clinic, you will go down to details and classification of these diseases. So write the periodontal disease diagnosis here, to be followed by the pulpal or periapical diseases, and then write down the caries and non-carious findings of the teeth. Go to the aesthetic concerns, then go to the defects in restorations. Okay, even the restorations, they can have a specific diagnosis. Okay, it is not only the caries, but also the restorations, like defective restorations, overhanging restorations, oral prosthesis present, any issues related to them that need management. Write them down, any findings related to implants. And in addition, we also write down the missing teeth. Okay, here is an example on a list of diagnoses, what we call also the problem list. For a chief complaint, let us take this example: fractured maxillary right lateral incisor with exposed dentine and reversible pulpitis. This is the diagnosis of the chief complaint. Then we go to the medical history. Our patient is having type 2 diabetes, well controlled with oral hypoglycemics. Or you can say type 1 diabetes, insulin dependent, poorly controlled, hemoglobin A1C 11. Okay, another disease for this patient, hypertension, well controlled. Another medical condition, allergic to penicillin and latex. So you need not to use latex in the management of this patient. So we have to write these medical diagnoses here. And then we go to the social history. He is a current smoker. We wrote this down because it affects our dental management. Okay, it might increase the risk for having oral cancer. Then we go to the past dental history. The patient is having sporadic dental treatment with last cleaning 3 years ago. Why we wrote it here? 3 years ago, it means that the patient is not following regularly, checking up his teeth. He doesn't go to dentist frequently, so you will expect kind of poor oral hygiene. Now, extra oral findings or our examination results. We identified actinic keratosis, hyposalivation. We go then to the intraorally to the periodontal disease, localized moderate marginal periodontitis or gingivitis. You can just say periodontitis, or you can say gingivitis. You don't need to go down to the details of this diagnosis. For caries, if you have multiple carious lesions, don't list them. Write multiple primary and secondary carious lesions. See charting, for example. Okay. Other findings related to the gingiva recession. Now, other specific findings related to the tooth, to the teeth, and maybe tooth structure loss. Here we have root sensitivity on maxillary right canine. There is cervical caries penetrating into the pulp. There is partial edentulism. We always have to write down or to list the missing teeth, or we can say check charting. Hyper-erupted or over-erupted maxillary left first molar, upper and lower partial dentures, fractured clasp, poor retention with upper RPD. We are writing diagnoses. I want to stress again on this problem list or the list of diagnoses. It is very, very important to prepare for your treatment plan. And in the clinic, when you have the form of treatment planning, you cannot refer the patient for, I don't mean you cannot, but it doesn't make sense that you refer a patient to have removable partial denture and you don't list partial edentulism. for this patient. How come you refer him for something that is not listed in your diagnosis? So to justify your referrals, you have to have a comprehensive list of diagnoses. Whatever listed in the referral should be already listed in the diagnosis. And actually, the diagnosis list should be a comprehensive one, as we have seen in this example. Now, we identified the diagnoses, we wrote them down, we used a logical sequence, we followed all the steps in the examination sheet and formulated the diagnoses. Now, for treatment options, suppose we have a fractured tooth. Now we need to know what are the various options of the treatment. We can say that for that fractured tooth, I want to have a crown. But I need to consider the mouth as a whole, not as an individual tooth by itself. So I should consider the periodontium, I should consider the TMJ, I should consider the patient oral hygiene, I should consider the fracture line. So these factors will be related to the dental finding itself, like the restorability of this tooth. And at the same time, I should think about the whole oral cavity, the whole patient as as a one unit. Not only considering every single tooth by itself alone. It should all put together. So the treatment should be at different levels. It should not be only limited to the first point here, which is treatment at the individual tooth level. Okay, it is not only treatment at the individual tooth level. A fractured tooth, you can treat it by, for example, RCT and post-crown, or you can extract the same fractured tooth in two different patients. You can treat by more than two ways or two methods of treatment. Why? Because we are considering the context of the rest of the dentitions. If that patient is having multiple missing teeth adjacent to this fractured tooth, if this fractured tooth is not a key tooth, then why should we keep it in this patient? To have RCT and then post-crown, and then we have partially edentulous patient. So you need to consider the treatment at the individual tooth level, if it is restorable or not. At the same time, you need to consider this treatment option in the context of the rest of the dentition and in the context of the whole masticatory system and the individual himself. If you have a patient who is obviously ill or not in a good health, supposedly he has, for example, open heart surgery 1 year ago, but he is not well. So why do you want to expose him to extensive dental treatment if he is in this situation? Okay, so consider the individual as a whole, not only sticking to the tooth level. We will talk about these now in the coming slides. Okay, now we want to think of a good treatment option at the individual tooth level. You need to have good knowledge in dentistry. But whatever lectures you will take, whatever references or textbooks you will read and memorize for the exams, there are still more information emerging and more changes in the literature. And you cannot rely in your treatment options on what you hear from your friends or from your colleague or from your even instructor. You yourself should use the evidence-based dentistry in treatment planning options. What is the evidence-based dentistry? I want evidence to base my treatment plan on. Without evidence, I will not proceed. So, first, to search for this evidence, you need to formulate a question. Like we search in Google, for example, you need a keyword, you need to formulate a question, and then you will search for it. It's better to search for, of course, in scientific reviews or Cochrane Oral Health Group reviews. It will give you systematic reviews that will collect for you all the published papers related to this topic. So you yourself can decide what is the correct or the most updated treatment option for that tooth. As we said, treating the individual treatment at the individual tooth level is not the ultimate treatment plan. Okay, so after you searched for this, the best treatment plan, best treatment of this individual tooth, you have to consider the individual patient needs and present this treatment plan to the patient. And the patient should be involved in deciding whether to go with your treatment plan or treatment option or not. So, what factors that can influence our treatment plan? Although you searched and you went to the Cochrane and you identified the most updated data regarding this treatment, however, there are some factors related to the patient that will influence your treatment plan. First, patient preference, patient motivation, systemic health, emotional status, financial capabilities. Capabilities of the patient are very important, the financial, because if he cannot pay, he cannot go for an implant, even if you think that the implant is the best treatment plan for this patient. Now, for us as dentists, what govern or what influence our treatment plan mainly is our knowledge, maybe followed by our experience and training, your evidence-based practice, the availability of a specialist around you in the clinic. You can consult or you can refer for the patient, and your lab support if you had a good lab for the prosthesis. This is if you are in a private practice. These factors maybe apply to you more if you are in a private practice. Okay, now let us talk about the factors influencing treatment plan and talk about the patient-related factors. As we said, if you think that RCT or endo treatment is the best treatment choice of a tooth, however, your patient, request is your patient doesn't like coming and going to your clinic several times. She is staying far away from the clinic. She cannot pay for the to reach you. She cannot pay for that. She cannot afford all of this hassle. So you will go for extraction, even if you think that this tooth is better to be treated endodontically. So a patient, 25-year-old female, and a second identical patient, both of them having the same dental issue or dental problem, but one have a good, the ideal treatment plan for her is RCT, but the other one is extraction. So the patient's belief and the attitude toward the dental care is an influencing factor in your treatment plan. It can change your treatment plan. The patient age also can affect your treatment plan and can change it. Even it can change the advice, the way you are advising this patient. Okay, you should respect his age. Now, the patient general health and his ability to tolerate your dental treatment. If a patient cannot tolerate the dental treatment, so you should not prepare a treatment plan for him that will not be tolerable. Like patients with neuromuscular conditions, patients who cannot maintain a good oral hygiene, so you cannot place a complex bridge for him because he will not be able to clean it. Okay, the patient willing to attend the dental clinic or their past attendance record. If the patient does not prefer to attend regularly or cannot attend regularly, maybe because of the work, of the family pressure, health, unemployment, or whatever. So don't put him, for example, under review for like arresting caries. Okay, if you want to put him on oral hygiene instructions to arrest caries, you may need regular follow-up for this patient. But your patient cannot attend your clinic, so you cannot do that. Okay, so preventive measures need close follow-up. If your patient cannot attend, then go ahead for restoration. Financial considerations, the cost will influence your treatment plan. The type of prosthesis, the type of ortho treatment, for example. Those costly treatments, they will be influenced for sure by the financial considerations of your patient. There are also some special dental considerations in the patient himself. Inside the oral cavity or in the oral cavity of the patient, you can check his oral hygiene status. Okay, if his oral hygiene status is poor, he will not be able to help you in controlling dental caries. Okay, so we need also, for example, to consider the pulpal and endostatus of individual tooth. If you want to have a filling or RCT or crown or a bridge. If you want to have a crown or a bridge, you consider the pulpal and endostatus of the tooth before preparing for fixed prosthesis. And other points that are related to specific dental findings in each patient. There is a point that you will be taking in the different disciplines in prosthodontics, in perio, in operative dentistry, which is called the risk assessment. There is risk assessment of caries, risk assessment of periodontal disease, risk assessment of all different aspects of dentistry. Risk assessment is that you will assess the patient for the likelihood of success or failure of the various treatment options. If you want to put the patient on arresting on preventive programs to arrest caries, is there a good likelihood of success for this treatment option in this patient? This risk assessment did not arrive haphazardly. It came from evidence-based studies. Okay, and we will not discuss the details of the risk assessment of caries or periodontal disease. You will take it in your courses, in other courses. Now, what are the phases of treatment plan? Let us summarize what we have discussed till this point. We mentioned that why we will have a treatment plan, why it's better to write down steps or sequential treatment plan, and we start treatment planning after we finish data collection from all aspects, after we finished examinations and investigations, and after listing our diagnoses or the problem list. And this problem list has guidelines. You need to start with the chief complaint, followed by the same sequence in your examination sheet, writing down the medical condition that will affect your management or treatment. So we need to list in the problem list anything that will affect our dental treatment or it requires treatment. So go back to that slide. It has 12 points for what to list in the problem list. Now we listed everything. Then we discussed the treatment option of every point. Like if I have caries, I have to refer to for restorations. If we have periodontal disease, we will refer for perio treatment. If we have irreversible pulpitis, the tooth is needing RCT or extraction according to to other influencing factors in our treatment plan. But in general, all of this should be put together in a 5 phases list. This list is of 5 phases. Systemic phase. Systemic meaning we are talking about the body systems, about the health of the patient. And we put it number 1 because sometimes you need medical consultation before you start any dental treatment. So number 1 is systemic phase. Number 2 is the urgent or the acute phase. Here we treat the chief complaint if it is pain or if it is of acute diagnosis. Then we go to the disease control phase. We need to control any source of inflammation and active caries. Then you go to the definitive phase, having definitive treatment like prosthesis, ortho treatment, and other treatments, and then comes the maintenance phase. In general, what we want in our treatment plan is to relieve or to have resolution of the chief complaint and to refer the following categories and arrange them in our treatment plan. Usually we start with the periodontal therapy and caries control, because this is what we call disease control. Okay, and endo also is a disease control. Some extractions are disease control. Then comes the definitive phase. Actually, if you go back, let us go back to these phases. In each of these phases, you can list the different disciplines. For example, in disease control, you have perio considerations, you have caries considerations, you have ortho considerations, surgical considerations. So the disease control phase can be surgical and non-surgical. Surgical because remaining roots are active area of inflammation. So extraction comes here in the disease control phase. But in the definitive phase also, to maintain the occlusion, maybe you need to extract an over-erupting molar. So surgery comes in both phases. Okay, perio in both phases, cons in both phases. Let us start with the systemic phase. Systemic phase, as we said, it is the patient's health history, and maybe we need to have a procedure or management plan before or during the treatment. So maybe we need a consultation with the health practitioner. Maybe the patient needs antibiotic prophylaxis. Maybe he has fear of the management. He cannot tolerate the dental management. Maybe he is taking certain medications that have side effects like anticoagulant, like warfarin. Or maybe he is having allergy. So any of these should come, all of these should come under the systemic phase because they need considerations. Here comes the acute phase. And in the acute phase, or the chief complaint, which is if the chief complaint is related to any of these, then it is acute phase. But sometimes the chief complaint comes like restoring or replacing missing teeth. Replacing missing teeth is not acute phase. An acute phase will be like symptomatic problems the patient may present with. So put an underline, a line under the word symptomatic. So symptomatic, like having pain, infection, swelling, broken teeth, missing restorations. So it can be provided even before any comprehensive treatment plan. Acute phase can be extraction, endo treatment, initial perio treatment, placement of temporary restoration, or repair of prosthesis. So we want to treat now the symptomatic complaint of the patient. If you go to the disease control, as we said, in disease control, we want to remove the etiologic factors of the dental disease, remove the cause of this dental disease, and stabilize the patient health. To eliminate this active disease, usually we eliminate caries and inflammation. And then we begin the preventive dentistry activities. We need to control the oral disease and the infection, and to stop occlusal and aesthetic deterioration. Okay, it is not the definitive. Now we are just maintaining, or we are controlling now the disease, and manage any risk factor that can cause oral problems. So here we are controlling the active disease in the patient mouth. As I mentioned, you can have perio, cons, prosto, you can have surgery. All of these disciplines can come under the disease control phase. These include extractions, endo, perio, scaling, occlusal adjustment, caries removal, repair of defective restorations, gingival overhanging fillings can be repaired. So all of this, we are eliminating the sources of inflammation. After we stabilized the patient and we controlled the disease, the dental disease of this patient, we have to follow up the patient before having the definitive phase. We need to make sure that He responded to our treatment. He is now motivated, and he is following our instructions. After that, the definitive phase comes. The definitive phase is to rehabilitate the patient's oral condition. This will improve the appearance and the function. As you see, what I mentioned previously in the disease control phase is that we can have all the different disciplines coming in that disease control phase. But when the disciplines are talking about appearance and function, then we call it definitive phase. In this case, we need to sequence again these disciplines like the operative, endo, perio, ortho, surgery, prosto. All of these need to be sequenced under the definitive phase. After finishing the definitive phase, in which we maintained the occlusion and the function, the prostheses are placed and the implant or bridges are placed, the occlusion is maintained. Then after that, we have to maintain what we have achieved by regular call and regular examinations of the patient. The regular re-evaluation, the intervals depends on the patient himself. For example, you can recall your patient in 9 to 12 months if the patient has stable periodontal health. But those at high risk of dental caries, for example, or periodontal breakdown, you need to recall them in 3 to 4 months. At the end, you need to always document your treatment plan. Write it down, maybe for legal issues, and so that your patient and your nurse and yourself will have everything documented. And generating the patient record containing all the information and the points considered in the treatment plan. And your patient has to sign a consent. In our health center, we don't sign consents at this stage. Maybe later on with our digitized system, there will be a way for taking the approval on our treatment plan. The patient should give us his approval. We can have initial treatment plan. Actually, the treatment plan is dynamic. It can be changed according to the changes in the patient's findings. There are always alternatives to the treatment plan, to the ideal treatment plan that we write. Sometimes you prepare a treatment plan, for example, of a specific tooth that you want to have a restoration placed. But once the patient go to the clinic and the cavity is prepared, then there might be pathologic pulp exposure, and the patient will end by having root canal treatment. So your treatment plan was caries removal and restoration, but the end result was endo. Sometimes you refer for endo, but the result will be extraction. So the treatment plan is dynamic. It needs to be following these general guidelines we talked about. Okay, this is the last slide of this lecture and the last lecture in our course. Please, if you have concerns, send me emails and we can arrange for a live or a conference or meeting, and we can discuss all of your concerns. Okay, thank you.